Perfect. Hello, everybody. Right. Thank you for joining us this afternoon. So hopefully you're in the right event. It's Multi-Professional Support Unit, NATH, and we are going to be talking about care coordinators today. So next, please. So just a few housekeeping for teams, and I'm sure you're all very aware of it by now, but make sure you do write in the most important thing I would say is in the chat. Make sure you do, if you're sharing screens or, you've got two people on there, do write your name in the chat and if you're logging on from your name, that's great. But if you're not, just check your name on there. It's just for the attendance and certificates if needed. Unmute yourself, but unmute yourself anytime when you want to talk. Raise your hand. Chat box will be monitored continuously. So, just make use of it. We'd like it to be interactive. And what else am I just thinking? What else we need to know? No, do keep your cameras on just for networking. But if you're eating in the background or anything, we don't mind. Right, so I'm just going to do a bit of introduction of myself and our special guest speaker today. So I'm Sarah. I'm one of the GPs in Nottingham and work for Nottinghamshire Alliance Training Hub as a GP associate and a medical educator. And we've got Darcie today with us. So Darcie, do you want to introduce yourself and maybe go to the next slide? That'll be great. Thank you.
Yep. Hi, everybody. So I'm Darcie Parry. I'm a lead care coordinator for a surgery in Bassett Law called Newgate Street. I'm also the care coordinator ambassador for Nottingham City, Nottinghamshire and Bassett Law as a whole. So I work with the NATH team doing the ambassadorship 1 day a week to try and look at all aspects of care coordination and where we can support the role. So currently being the ambassador, we're looking at promoting the care coordinator role and trying to enhance it as much as we can. So we kind of get everybody on the same wavelength, make sure that all practice managers and anyone that's really in a management setting are aware of what a care coordinator is and exactly how to utilise it within their PCN. I'm currently the allocated person for care coordinators in the surrounding areas to contact regarding any training needs that they might have, whether this can be the mandatory training or anything that they're just interested in looking at to do with the role just to enhance it. Looking at their educational interests, whether there's any area of primary care that they are wanting to try and develop into, and looking at how we can support that. Looking at apprenticeships in the same area as educational interest, kind of looking at how we can utilise those to get them further on in the career progression if that's what they wish to do. And then looking at the implementation of their job role as well, so they can contact me if they have any issues or if they have any queries regarding how their job role should actually be used within their primary care network setting. So what they can do, what they are kind of able to do on a level of support basis. I offer like one-to-one kind of peer support meetings for people. So these can be an initial meeting when they're looking at joining the peer support network that we run. So these are just normally Teams meetings or over the phone where they can ask me any questions that they've got regarding the peer support or regarding care coordination, whether they're new to primary care or they've been in their post for quite a while. It doesn't matter. It's open to anybody. We look at also creating networks to understand the role better and make connections. So this is kind of associated around similar job related interests. So we're trying to push people who take on similar day-to-day roles, such as if you have a mental health care coordinator or a cancer care coordinator or someone that deals with long-term conditions, respiratory, looking at people that kind of have the same job role, that they can then create smaller peer support networks so that they can speak about their actual job-related interests and what they base their time on, so they can talk about QOF and different areas of best practice that they can support one another with. So that's kind of where we're at with the ambassadorship and what we are trying to achieve. There are a couple of other bits that we're just looking at the moment. So it's promoting the role to stakeholders like people in the ICB and areas of interest, different people that offer different education opportunities and stuff, so they understand the role, how it fits into primary care and how we can further develop the role, so people have got opportunities to kind of progress do extra training, whichever avenue they're wanting to take. So looking at supporting that with obviously making stakeholders aware of us. And then just going back to the career progression, we've just been making a career progression kind of diagram in a way that outlines all of the areas that you can go into. It is currently just restricted to primary care because that's what we've been basing the work on at the moment. It might look at expanding into kind of a secondary care setting if we have a need for it. But at the moment, we're just looking at trying to push development and progression as much as we can. So we're visually popping together all of the different areas we can take, such as, you know, going into pharmacy tech or going into social prescribing, or looking at ways to get into becoming a GPA and trying to kind of like expand ourselves through the other R's roles, so how we can reach those. So that's kind of like a quick rundown of what the ambassadorship is at the moment. So if anyone is a care coordinator or has any care coordinators within their PCN that might benefit from support from us, please do get in contact with me. I'm more than happy to help anybody at any time if they want to book a one-to-one or just join the peer support. The peer support is currently run as a Teams chat. We share a lot of opportunities. It's not just me, so it's not just me sharing stuff. It's open for anybody to share anything, whether it's areas of best practice, different events that they might come across in their own local areas, whether it's services that might support the job role. We can share anything that kind of would be used by other people. So there's the chat, and then we have a meeting via Teams at the moment once every 8 to 10 weeks, just as a catch up and a face-to-face kind of meeting, just to make sure everyone's okay, and just to really have a bit more of a face-to-face peer support instead of it all just being typing on a chat. So there we go. So just a little
Sorry,
rundown.
Darcie, just
Go
a question. So that peer support is just for the care coordinators to come, isn't it?
Yeah, so
The
peer
meetings,
support is
obviously,
just for, it's just for care coordinators, where they can come and they can, like I say, they can share opportunities, or they can just basically ask a question to the group. So there's currently over 30 participants that we have. So we have over 30 care coordinators in this peer support network at the moment. But they can come on, they can ask if anyone knows of, for an example, if anybody knows of any additional safeguarding training that they can access, or if anyone has kind of doing something to do with quaffing mental health and can ask for some pointers on how they kind of like support it within their surgery and contact patients and the processes that they take. And it's all about sharing similar interests, sharing ideas, sharing best practice, so that we can all kind of bounce off each other and support each other within his job roles. But yeah, it is just care coordinators that do it at the moment. But there is an ambassador for each R's role, so it's not just myself with a peer support network of care coordinators. So if you do have social prescribers, GPAs, you know, pharmacy techs, there's an ambassador for anyone. So if you do have anyone that does want peer support that isn't a care coordinator but are an R's role, I can also point them into the right direction of who they need to speak to access that.
Yeah, so that's right. NATH has got all those ambassadors, so do reach out, you know, if you've got any. Yeah, thank you for clarifying.
Okay. Yeah, so the role of a care coordinator. So this is just a rundown of what a care coordinator does. So before I go on to the next slide, a care coordinator is quite a vast role. So people can specify in many different areas of support, many different areas that they actually base their work around. So it's not a role that's directly set. So you will find that care coordinators in different areas will do slightly different things and manage things differently, but that's just dependent on their own primary care network and their needs. So moving forward. So a care coordinator is a member of staff that's employed under ours, and they are there to support patients in a person-centered way and make their care easier to understand and maintain. So this being said, this is basically where a person will tend to have a specific condition or conditions that a care coordinator will base their time on. And these people will have access to the care coordinator, who can help them with accessing appointments, help them with accessing information regarding their issues, you know, so they can support them in any way that they realistically need, whether it's managing their appointments for them, combining their appointments, whether it's referring them on to different support services that can help them. For example, if it's a patient and you're a cancer care coordinator, you can take that patient, you can be a point of contact for them within your primary care network, but you can also signpost them onto different services that can support people with cancer in other aspects. Like we have Aurora that's local to us, where they can be referred into them and they can access all sorts of wellbeing services, you know, gym services, anything that they might find supportive. So we kind of try to be as person-centered as we can around that individual. We do tend to focus on a particular cohort of patients. So there's a little list of the ones that I'm aware of that are in my area at the moment. So there's cancer care, long-term conditions, mental health, learning disability, severe multiple disadvantages. But again, within a primary care network, you could have a care coordinator that just focuses on cancer, and they can provide very tailored support towards the cancer patient. So they can then be trained to do the 3, 6 and 12-month cancer reviews themselves. They can create those bonds with those patients where they are basically the point of contact for anything that they need. So some people will work in that way where they are the core to that condition for kind of everything to do with primary care and doing all the signposting and that, whereas other care coordinators will work with a vast amount of different areas, such as they may have mental health, learning disabilities, care homes and severe multiple disadvantages all in one. So although they can't really provide that level of tailored care, they're still there to support a particular cohort. So it could just be inviting all of these patients for their reviews around those conditions. So your mental health patients, it could just be care coordinating by inviting them for the reviews, trying to, you know, support them to attend as best possible, such as sending them reminders, sending them letters, looking at reasonable adjustments if they need them, such as, you know, side rooms and stuff like that for certain patients. So it can be whatever level the primary care network needs them to work for. So that's how it kind of works. So again, that's just the same thing that I basically just said, looking at combining appointments and stuff. This is something that within my PCN that we have found quite beneficial at the moment. So it's combining their appointments. So if somebody does have kind of like respiratory and diabetes, this is a big one for us at the moment. We're trying to get them to come in as like a long-term condition review, so that they only have to come in once to see the nurse instead of them having reviews at different times of the year. You know, they're having to come in, they're having to remember what they're for, they're having to repeat tests and stuff like that. Whereas if we're combining appointments, it's proving to be a lot more manageable for the patients, especially with them trying to get their head around different conditions all the time. So that's something as care coordinators that we can do. We can look at making, again, a lot more, sorry, got something stuck in my throat. We can look at getting the appointments combined so that they are kind of monitored more frequently, and they only kind of have to tell the story once, which is a big basis around what we try to do. So we look about telling the story once. People never just tell the story once, because there's always aspects where they do need to tell it more and they need to explain things more. But it's about them seeing that one nurse say that they want to see every year, and they come and see them once, and even though they repeat bits of it, they've still got that familiarity. So it's about looking at how you can support it in that kind of way. And then the other big part about care coordination is we are one of our staff that have the time to be able to create the about me's and the personalised care and support plans for certain patients within their conditions. This is a big thing that we've found, especially for your mental health patients, learning disability patients, care homes and cancer specifically. So looking at these, it's kind of assessing them with the patient themselves, the carers, anyone that is kind of supporting them, and creating these documents which are kind of like just personal to them. So it can be things like, particularly with care homes, whether they have any safeguarding, whether there's dolls, whether there's respects in place, stuff like that, and then little bits about them, like how they personally like to be communicated with. what's important to them within the healthcare. If they need any reasonable adjustments, anything like that, they can all be put into these plans, which then ideally should make their care more person-centered by making it available for other clinicians to see. So when they are seeing them, they have all that information there that they could need. And it also involves the patients in their care and makes them feel more listened to and more heard, because there's more of an understanding of them as a person, as opposed to just a name on a screen that someone will see and be like, oh, so and so's got, you know, they've got a chesty cough. It'd be, oh, they actually quite frequently suffer with it. It says it in the personalised care and support plan. It's about trying to create those pointers so that they feel more heard. Okay, so that's just a bit on what we can do with those. And then, yeah, just some areas that we can support with, because as I say, people work differently in different PCNs. So it's about kind of looking at the different areas that we can work with. So some care coordinators might send mass invites for reviews for a certain cohort. Like I said, mental health reviews, they could be sending hundreds of invites for these reviews, you know, every month for people to come in and see them and chasing them and monitoring them. So there's that area we can help with. There's being a point of contact for certain cohorts to discuss and personalise their care. That would normally be through them contacting us for any issues that they may have, and also supporting them with the care plans. We have been quite well known to support vaccination clinics such as COVID or flu. We've actually gone on in the surgery that I work for to have a vaccination lead care coordinator that bases all their time on the vaccines and stuff. So that's an area that we can be quite vastly involved in. Yeah, so carrying out certain reviews if they're required and we're trained properly. So as I say, cancer care, we can actually do the cancer care reviews. We can do the learning disability reviews. We can do mental illness reviews to an extent with clinical input. So there's areas like that where people can utilise care coordination to actually have us do those reviews for them. So it's kind of freeing up clinical time as well, but that is completely, again, dependent on PCN and what their process is that's already in place for these reviews, and whether that's kind of like a need that they would benefit from. Again, vaccinations, we can look at supporting the childhood vaccinations and managing and coordinating all of those, including the postnatal care for people. And then we do tend to do quite a lot of referring on to local services. So when we have patients that are from any area of care, any cohort, realistically, we can put them on to, you know, weight management, smoking cessation, talking therapies, anything that us or any other clinician might feel necessary for them. So we are fully capable of doing those referrals where needed. Yeah, I'll just take a little second there before I go on to the pathway. Is there any questions or anything, or are we okay?
Nothing in the chat, but please feel free to ask anything at this point. You can either raise your hand or unmute or write in the chat. Doesn't look like we've got anything, but yeah. please think about it and continue to use the chat box. Thank you.
Yeah. And yeah, so the pathway to becoming a care coordinator, the care coordinator pathway realistically is quite small, because we are the only ARS roles that don't necessarily need any qualifications to become one. So we do look at a certain person spec, though, realistically, to become a care coordinator. So we do expect people to have worked in some kind of health or social care setting, or kind of like support role, which is in direct contact with service users, families and carers. This could be on a one-to-one basis, or it could be somebody that's done, you know, home care. It could be anyone that's kind of got that caring nature about them, where they have kind of supported people with health conditions within the community, or whether it's private, whichever. We do look for people who have worked in an MDT kind of environment, so, you know, working with other professionals. We all know what MDT is, really. So looking around, working with different professionals to support people with the needs. People who've worked with cohorts of people where best practice is supported, so vulnerable people or the elderly, that's always beneficial realistically with any role that's coming into primary care, because that does tend to be a large cohort of the people you will support in this role. So those that are vulnerable or elderly, they do tend to be the people that do need the support from us. Experience and support planning is always beneficial, because again, that is something that we can do within our role to support these people. So it's always good to look for the experience through that. And then for the understanding and skills required, we always look at, you know, people complying and understanding the regulations around health and social care, normally from an employment setting where they've obviously worked within it and they're quite aware of all the, you know, general policies and procedures that are in place. That they have a general understanding of personalised care and what it is on a basis, on just like a level basis of what they think personalised care is, and, you know, how it can be implemented within the work day that we work. People understand the importance of EDI, so equality, diversity and inclusivity. Looking that people obviously understand why all three of those are vital within this role. Looking for people who have strong organisational skills such as diary management, prioritisation and record keeping, because it's something that you will use day to day, and you do need to be organised within this role vastly because of the amount of people that you do tend to support. So you need to be able to prioritise, you need to be able to know where you're at and when, so that you can support people to the best of your ability. Yeah, people have some understanding of safeguarding children and vulnerable adults policies, because that is something that will always come into play, even if you feel that it doesn't necessarily within your role, it's something that could always crop up. So it's very important that people are aware of safeguarding and what to do in those certain difficult situations. And then again, meeting DBS reference standards and criminal record checks, which is the same for any role in primary care. And then there is quite a lot of people aren't actually aware of this, which I do tend to badger on about quite a lot. There are 3 mandatory training requirements for care coordinators, which a lot of people are not aware of, and they should be done as soon as possible when a new care coordinator is in post. So there is actually a 2-day PCI accredited care coordinator course that all care coordinators should do. This can be partly funded, it can be fully funded, but it just depends on kind of finances that are available. I know that NATH do a bit of funding for this, but again, it's dependent on how much of the funding is there and when people are requesting it. But it is something that does need to be done by all care coordinators that are in post. It outlines specific ways of working, and it goes through all of the care planning and everything that we should be doing within his role. So it's a great starting place for people to do, and it is mandatory, so everybody should be doing it. And then there's 2 e-learning modules, so personalised care and support planning training, which again, that's e-learning module, and shared decision making, because they are 2 things that we will all touch on normally on a daily basis, but again, it's all completely role specific. And these are all accessed through the Personalised Care Institute website, which is a great website for training, and they outline all the mandatory training of the R's roles, but they also have a lot of additional training which can be used in any circumstance. They look at training for specific conditions and specific ways of working, you know, working with kind of difficult conversations and that sort of stuff. So there's a lot on there that you can also benefit from.
Yeah, okay. So we've just got some, so Joanne did want to know the difference between the care coordinator and care navigator. And then Rebecca said that I must admit I've no idea. I had no idea the role of care coordinator was so vast, and it's fantastic. And I agree with that, actually. I was just going to say on that, do you have like a referral criteria? Again, obviously, I think you mentioned it very clearly that PCNs, the roles would vary depending on what area there is and what the requirements are. But do you have, like, when people are referring it to you, do they normally just task you, or do they to see if that's in your remit, or do you have like a referral form or criteria or anything like that at all?
We tend to work in our team, we work through tasks, and we have our own task list. We work on a system 1 basis. We all have our own task list, but then we also have a care coordinator task kind of inbox. So anyone that's internal to the primary care network, they can task it to a particular person if they know who they're tasking to. If not, they can just task it to the care coordinators, and I normally pick it up as the lead and I will send it to who it needs to go to, or then we just send it back to somebody if we need additional information. If it's not us, we can forward it on to different people, but we work through tasks. I've personally never come across a form or anything like that, because nothing that we do tends to be that in depth that it requires a form basis of information. but other people might use one. I'm not sure, but I've never come across it myself.
No, that's fine. That makes sense. So in each PCN, do you think there is like a lead care coordinator, or again, does it vary? Do you know?
It completely varies. So some places will just have one care coordinator. Some places will have 7. It's completely dependent on the needs of the PCN, of what funding they can get and how they work things. So I know some primary care networks have kind of like 4 social prescribers, 2 health and wellbeing coaches, and 2 care coordinators, that kind of thing. Whereas our surgery has 5 care coordinators and 2 social prescribers. We've just got another one. So it depends, because with care coordination, social prescribing and health and wellbeing, they kind of can work in a triangle basis of how they all support each other, and they can be pretty similar roles, but still do completely different things, and they integrate quite well. But it depends on the needs of the PCN as to how many of each they have. So it's a bit of a mix. But with lead care coordination, that tends to go on experience and what kind of roles the people do themselves. So it's a difficult one. I'm a lead for our PCM because I've been there a lot longer than the others. I trained them all up, and I kind of oversee the whole department of every area that we coordinate for. So I know how to do everything. I oversee them all and what they do, but I also have my own job role. Whereas the others just come into work and they do the job and they're not overseeing. So it's just that kind of thing where
no, that's fine. That makes sense, actually. And I think it's interesting that you said that some areas might just, because I was going to say some of the things might be picked up by social prescriber, or might be, and I think that there might be an overlap, and often that's what I meant by, if it's not appropriate, but if you know the other person might be better at dealing with this, you would probably just refer or signpost to that, I guess. But it's often, as a GP, I would find it difficult. Where do I? But I suppose when they work in your surgery, you get to know them, and then you get to know what their sort of caseloads are like.
Yeah, we do. And what I regularly do, which I do find helps a lot, is everybody understands social prescribing, because a social prescriber is a social prescriber. You know what you're kind of doing with it. Whereas care coordination, it's such a varied role, and there's no necessarily set thing for people to do. It kind of developed PCM specific. So what I tend to do is whenever we're getting something new onto our team that we're dealing with, I make sure that everyone's aware and exactly how to refer into it or signpost to us for people to get support from it. And I also have a document that's got every care coordinator on and every single thing that they deal with. And I make sure that every time it's updated, it's passed around and I get read receipts off people. So I know that people know where things are going to, but that's just that.
Yeah, that's perfect. That's really ideal. Yeah, that's ideal situation. That's great. Thank you. Anybody else got anything, or should we move forwards? Doesn't look like it at the moment. Okay.
So this really is just a bit. This is the end part of it, but I added this in last, literally like yesterday or the day before, just because this is a very, 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 very common question that you get. So these care coordinators were put in place in 2020, I believe. Was it 2020? Yeah, about around 2020. So we've been in post for about 4 years. And it was a role that wasn't necessarily understood by anybody. It was kind of like, oh, you can have a care coordinator, you can have funding, and people were like, great, we don't really understand what it is, but let's put them in place anyway. The role's developed vastly in all areas of what we can do. Then along came care navigators. So a care navigator, to put it simply, a care navigator is a PCN's definition of a receptionist. So all of our reception team have become care navigators. It's a new name for the role, but with them being care navigators, there's extra bits to it that they do. Whereas a care coordinator, we are kind of cohort specific. So I've done a little side by side list. I'm just moving the screen because it's blocking the writing for me. So I've tried to detail it the best that I can, but a care coordinator tends to deal with their own cohort of patients or their own cohort of illnesses. So for example, it could be a care coordinator will base their time on mental illness or on cancer care or long-term conditions. And they support the ongoing care planning and arranging reviews and support for that specific cohort or for a specific patient. Whereas your care navigators will work in a PCM and they will work with all patients within that PCM. But they work primarily on a reception or admin basis, and they will be there to book on the day appointments, order medication, and dealing with clinical requests. So it's more of an acute area that they deal with. So it's kind of like on the day and tasks from GPs and stuff that could be for any patient to do with anything. So whether it's like communicating the test results with them or, contacting them to arrange a follow-up appointment. It's that sort of thing that the navigators do. So they will navigate patients around the surgery, but by kind of just putting them in for an appointment with somebody or contacting them on that one kind of specific basis. So they will just ring that person once, tell them what they need to know, book them in for what they need, and that's it. Whereas we take on people and we support them time and time again with different things, whether it's reviews or whether it's care planning, etc. So that's the difference between how we communicate with people. So we, as care coordinators, work with specific patients to support the needs, and we can make necessary referrals. So this can be, like I said previously, where we take a patient on, say, mental health, but then we can actually refer them on to weight management, smoking support, other mental health services, stuff like that, because we kind of have those detailed conversations with them where we might figure out other areas that might support them. Like if it is mental health and they are struggling with smoking, we can think, oh, we'll refer on to smoking cessation and they might be able to help. Whereas your care navigators are kind of like a first point of contact level of support. So they will answer the phone and it'll be someone saying, I'm struggling with my mental health, I think I need to speak to somebody. It'll be, right, I'll get you in with a GP. We'll get you in with a GP, or we'll get you in to come and speak to somebody, or I'll give you the number for the crisis team. And it's not as an in-depth conversation to kind of identify those areas. So that's the difference in the communication level. They're kind of like there to just say, right, this is what you're telling me is wrong, this is what we can do for you, and we'll put you in to see somebody and stuff like that. We have care coordinators tend to have the time to get to know patients and their needs to create tailored and person-centered approaches. This is what the job's based around. So, we create those kind of bonds with patients. They see us as a point of contact. We're there for them whenever they kind of need us as much as we can be. Whereas your care navigators, they're kind of like dealing with acutely presenting patients and their initial medical issue. So they listen to the needs, but they act accordingly. So like I've just said, booking on the day GP appointments and stuff, ordering medication for them, booking appointments with nurses and healthcare assistants and stuff like that. So it's just a different way that we kind of support them. And then there's a difference in training between care coordinators and care navigators. So care coordinators are trained thoroughly in person-centered support, planning and shared decision making. It's part of the mandatory training that we do. And then we also tend to access cohort specific training. So me, for example, I am a mental health and learning disability care coordinator. So I have done X amount of training on mental health and dealing with difficult conversations and suicide and stuff like that. And then learning disabilities, so much e-learning and things on how to support people and reasonable adjustments and stuff. Whereas your care navigators deal with that many patients with that many different issues, and they'll all fall under so many different remits. They kind of have a basic training of your system training. So system 1, kind of that training, they are thorough in system 1. Like our care navigators know a lot more than me about system 1 and stuff like that. They are absolute whizzes on it because they need to be, because they need to know the insides and out to know exactly where they're referring people into and where they're booking them. And they do have a lot of patient-facing training because they do see people constantly throughout the day who are coming up to the desks or calling in on the phone and speaking to them about different things. So they have a lot of training on that. And then they also tend to have additional training in other roles that are specific to them, such as kind of like dealing with difficult conversations and things to do with like dealing with on-the-spot conflict and things like that. So there's a slight difference in the training that we tend to do. They deal a lot more with the unknown than we do. So they base their training around that kind of thing. But yeah, is there any questions about the differences between care coordinators and care navigators? Just because I know it's such a big thing.
Sorry,
Yeah,
I was just going to say that. Yeah. Sorry, I was just going to say then it comes opposite, doesn't it? So what is the difference then between a receptionist and a care navigator? And then are they also care navigators on the front desk, or are they like at the back, or how does it work from that point of view then? Because I've understood that there's difference between navigators and coordinators, and then
so your care navigators, so it kind of became an umbrella term. So you had receptionists, and then you had so for example, our service, we had receptionists, and then we had kind of people in the back who dealt with prescriptions, and we had people that would sit there and deal with test results all day, call centres, people that would deal. We had one lady that dealt with the emails that are coming in through like our SMS email, where people could email in stuff like basically care homes. They all became care navigators because they all navigate care throughout the surgery. So it's kind of an umbrella term for anybody that's admin based in a way. So anyone that deals with that patient contact, that deal with acute on the day issues, and that are kind of like not dealing with them directly, but they're kind of signposting them to other people, like whether they're booking them in with a GP or the query in pharmacy or things like that. That's a care navigator. So it's the umbrella term for admin.
Okay. Yeah.
If that kind of summarizes it a bit better.
Yeah. No, that's what I thought, but I just wondered then, how would you differentiate between then the reception team or admin team and that? But you're saying that it's kind of a general term.
So a care navigator is an umbrella term, but basically when we say care navigator where I work, it's the receptionists. But then you'll have your prescription care navigator, you'll have your SMS care navigator, you'll have a test results care navigator, and they are the people that kind of are admin based, but they like specifying test results or working the emails and stuff like that, or call centre care navigators. We have stuff like that.
Yeah.
So
I think that makes sense now. Yeah. Thank you.
Yeah.